Women in your 30s and beyond, are you tired of being told how to feel? Like all of the products are forced on you? Doesn't it feel like these big companies categorize you when the truth is, they don't know you? If anything I just said struck a nerve, listen up. I'm Dr. Jila, an OBGYN and women's health expert. This is my podcast, Her Time, Her Health with Dr. Jila. All right. Thank you for being here. I'm so excited because, I wasn't able to make it. So it's great that I'm going to get all the, the lowdown on what went down at the Menopause Society meeting this year. So I'm excited for you to kind of go through it with me. Just kind of start shooting off, you got there, Friday, right?
So I got there for the inaugural session. Before the session, this is my 6th Menopause Society meeting. So there were doctors in the room who've been there for 25, 35 years. And that's really what I love about these conferences is seeing how much legacy and work has been put towards the research of women's health. And this year, I really noticed something different in the messaging. It was very positive as we longevity specialists really celebrate what is the distinction between health span and longevity, understanding how ovarian aging is really the organ that tends to be, as Dr. Jennifer Garrison said from the Buck Institute, the pacemaker of our lifespan. And I think that's really important and helpful to hear this. And we had almost 2,000 scientists, doctors in the room, and it's good energy in that room. So what I was impressed by, first there was a big announcement, and that is the FDA approved our second medication that is non-hormonal for vasomotor symptoms. And really the data is quite compelling. I've actually just sent my first prescription today for my patients who are already having breakthrough symptoms on the other FDA-approved medication. So Dr. James Simon made that announcement, and it was really just within an hour of the FDA approving it. Wow. So that was pretty historic because many researchers in the room, some of my favorites, Dr. Thurston, Dr. Maki, of course, Dr. Claudio Soros, they had all been contributing to this research for quite some time. And what are these candy neurons, these neurotransmitters that change, that regulate thermal sensing. And so this was, I think, really important as we look at the science of what happens. And the first session was perimenopause. So it's really nice to hear that perimenopause is a word, it's a thing. It can start as early as 35, and it's different than premature ovarian insufficiency, and really putting out a lot of science here. And I think reminding this big audience that women will present as early as 35 with fluctuating symptoms that can include hot flashes, night sweats. More than 40% report forgetfulness. And I thought it was really compelling when they said most women say we were not prepared for this. The whole, I'm not feeling like myself. What happened to me? What is going on? And they made an analogy saying, listen, adolescence about puberty, why don't more women know what's coming? Most women thought this happens after 50. So I think that was a really helpful message there. And one of my favorite presentations from the perimenopause segment was the atypical presentations of perimenopause. And, the burning mouth
Tell some
syndrome.
Of the symptoms that they went through, Catherine, like with the perimenopause, because, there's a slew of them. It could be anywhere from your head to your toes. So what were some of the outliers that we don't typically pay attention to?
Yeah. So to remind your audience, the classics, I could say itchy, witchy, sweaty, sleepy, bloated, forgetful, moody, super snacky. And then it's really the brain fog, forgetfulness. But I thought it was interesting, burning mouth. We have estrogen receptors in the mouth and in the auditory canal. So we hear this itchy ear, ringing in the ears, a lot of sensations above the clavicle that are different and can be confusing for women. So, and we see this too. They end up seeing so many physicians. But these estrogen receptor changes and activity can change our hearing. And we know that can be a risk factor. But really the biggest issue is sleep. Sleep is so key. And when sleep is disturbed, of course, our health, our anxiety levels are different. The flashing, the flooding, the contraceptive needs that are unique to this time of life, and how really we have to personalize therapy and really look at each woman uniquely. That really requires in conventional medicine more than one visit. A visit to say, yes, this is real, this is happening, let's schedule a separate time. We have the luxury of a private practice where we aren't so constrained, but for most women to know you're not alone if your doctor's rush didn't have time to schedule this. But I do think more physicians in the room. There were psychiatrists, there were physiatrists, many endocrinologists, and I love that because there are hormone specialists, and of course gynecologists, many internists. Just starting off with perimenopause, saying that it's real, the symptoms are real, and that you can treat safely with hormone therapy. And a hint of research showing that the sooner we treat, what is the window? And we know, and as I tell my patients, there's no unsafe dose of estradiol that I can give you as a patch, a gel. They're such low doses compared to what most women in their reproductive health span are taking for suppression and keeping the cycle and all the fluctuations better managed. That was one thing, and I think to really highlight too that the ovaries are the architects of the health, the pacemakers, they communicate with all of our other organs. So as we get these changes in their function, we really start to see the changes of aging. And so that will turn into women not feeling like themselves, the sexual changes, all of these domains that we're seeing. But importantly, the lipids, the cardiovascular risk. So that was a great session too. We really had a cardiovascular 101 assessment of how important it is, what the difference is with how estradiol health signals and increases risk, if it's by endothelial resistance in the blood vessels, if it's the visceral fat, the changes in weight, and of course the sleep insufficiency and the stress. And Jila, what I was
all of this.
Yeah. They had a cardiologist who literally does mental stress tests on her patients, mental health. So she will literally can induce coronary vasospasm and our microvascular dysfunction of our small vessels by using words that invoke anger and agitation.
And then she would see that on the spikes and see wow.
Yes. And
that's
so
impressive.
We know too. I agree. And I thought, how many of us know we can tell our blood pressure's up. We can tell stress is really changing the pharmacodynamics, of our sympathomimetic system. And what is a hot flash or a night sweat? It's just a flood of stress to the body. It's changing the blood vessel circulation, and that's changing the perfusion of our vital organs. And we will start to see a woman's labs change, her blood pressure change, her weight change.
Did they give any specific parameters in terms of lab work or lab testing in the perimenopause time window? Did they say any or give any guidelines?
The guidelines still stay. There's no doesn't
test.
help to check the labs. Meanwhile, we get some lectures where, of course, when a woman comes in with hypothalamic amenorrhea, you need labs. So I think it's helpful for a woman to know how her FSH is trending, how that can correlate with symptoms, that it's not just in her head, it's real. So if her FSH has been under 10, and then all of a sudden it's in the double, triple digits, and that's correlating with her presentation, I do think that's helpful. But that's not in the guidelines.
No, and again, we're all doing a lot of this, we're sticking to the guidelines as best as we can, but there are different circumstances. I think that you need to kind of think outside the box and look at the whole overall picture, especially when we're doing, holistic, all women's health. You have to look from, top to bottom to make sure we don't miss any other underlying conditions. I was curious, did they come up with any time of age or age range for perimenopause, or are we still going with the 35 to 40, the 5 to 10 year window, late 30s? 30s, early 40s.
Yeah, that's what I recall was about
Yeah.
35 to 55 is that time of perimenopause. And I think that's about right. But also really appreciating how important it is to not miss, because 1 to 3% of women will have this hypothalamic amenorrhea, which will impact their aging trajectory if it's osteopenia, osteoporosis, cardiovascular disease, non-surgical menopause, right? Of women who maybe they have an underlying endocrinopathy, maybe it's related to their feeding, their stress, their environment, but that's where I do think, even though the guidelines say, we know 20% of women are going to go through perimenopause with a lot of symptoms, 50% will feel a little bit of something, and 20% say no blip, no problem
at all.
Yeah.
I want to go back to the medication that was approved, the FDA, the new approval.
Yes.
From what I was reading on that one, we know Veoza, or the original, right, that was released a few years back that we've all been using, was specifically for relief of vasomotor symptoms, hot flashes. And I think the new one that was just approved is not only for hot flash relief, but they found improvement in sleep as well. So I think that's why this one is such a big win for women everywhere.
Yes, and this has to do with these neurokinins. The NK3 mediates the hot flash. The NK1 mediates the sleep. So this new drug is working on both of those neurotransmitter receptors, right? And they're both mediated by estrogen decline. Yeah, so I think too we will, and really sleep is such an important domain of health and longevity. So I think it's an important thing to note there that we have the dual receptor. And so have you prescribed it yet, Sheila?
Not yet, but I have it on my docket. I'm ready to go with it just because I do love having non-hormonal options for my patients.
Oh, absolutely.
The way we prescribe to our patients is really, I want to start with the nutrition and the supplementation and non-hormonal remedies before really getting to the hormones, if we get there. Because some women will never get there, and other women we will. And as you know, there is a subset of women who aren't candidates for hormones, despite everything that we know. It's a small population, but nonetheless, we need to have other options for these patients. So it's great that we're coming up with novel things apart from just hormones, and that we know and research studies have shown are working, effective.
And this was really the biggest.
Okay, so we talked about perimenopause, and remind me again, one of the reasons I wasn't there is because they sold out before I could buy a ticket.
You got to buy it early. They've been selling out for years. Yeah.
Every year I hear it, and I didn't think it was going to happen to me, but, you know, my mistake, learned from that, you know, and I will definitely make sure I buy my ticket again, you know, as soon as they release it next year. That way I'm there. But the mix of practitioners, I should say, number one, I saw that the number of enrolled members of the Menopause Society doubled.
Oh, yes, it's been going up.
I saw the graph, and it was like, you know, 2,000, 3,000, 4, 6, 12,000.
Yes.
That is unheard of, and that is what we need. That is the movement. Because women in that room are the ones who are going to be helping women going forward. You know, they go to the meeting, they get the information, they take the exam. Then we have more people on the front lines helping women from all different backgrounds and fields. And I think that's where our power lies. I think that's amazing.
And the beauty of this is it's an elective. It's a selection bias of people who are very motivated. This certification by the Menopause Society is completely elective. You don't have to be, you know, as a specialist. It's not a board certification that gets you credentials at a hospital, but it is the distinct amount of doctors who are saying this is important. And we know 51% of the population are women, and this happens to all of us who have the privilege of getting to live long enough. It's such an opportunity, especially as we study aging, how we can help women age more favorably. I think without understanding hormones and these changes, you really potentially doing a disservice to your patient's longevity without understanding.
If you're not paying attention and if you're not really understanding what's happening to them, because this is a segment of what's happening in terms of women's health and well-being going forward. Like I always say this, I'm like, we are not just treating you with hormones just to treat your symptoms. We're preventing disease formation in the future. So that is our goal, is for you to live as long as you're going to live, but in the best health possible.
This hypothesis, I think, is important as we studied the aging woman is, can we use non-hormonal options? Because we do see a separation. We can't, and this was, addressed many times during the presentations, was that estrogen cannot and has not been shown to reduce cognitive decline. We hear it, of course, anecdotally, but in the data, it doesn't show up. But we know the sleep is very important. So if these non-hormonal options, cognitive behavioral therapy, all of these other domains can help, that's important, because we know we can treat a lot of these changes. The body's very adaptive. We know 50% of women over the age of 50 start having high blood pressure, start going on cholesterol medications. Importantly, too, that age between 45 and 55, highest rate of suicide for women. We see women opting out. So I think from their function, their sense of well-being, it's so important for doctors who are prescribing hormones. If you don't know the guidelines, if you don't come to the meetings, if you haven't studied the guidelines, it's important to know what the guidelines are. You may not agree with them, but many doctors in the room, and one of the reasons I go is I hear the best scoop on how to prescribe off-label by the doctors in the room, because they've been practicing and taking care of women's health and caring about women's health for a long time. And that's where I really get the best pearls of knowledge.
And that's exactly what they are. We know the basics, and we've been doing it.
Yeah.
And a lot of this is trial and error, because remember, each patient's anatomy and biology, physiology is completely different. So we need to be able to adapt to that, see what their symptoms are, and how are we going to modify their treatment regimen per se. And being in these rooms, you do get these little pearls of wisdom where you're like, oh, I wouldn't have thought about using maybe a progesterone-containing IUD per se, to control different symptoms, but still continue using hormone therapy in addition to. So there's a little bit of these things that you pick up when you are in these rooms with all the experts there who are really doing the research on it, the groundwork, writing the papers, and writing the textbooks. And I love getting that information straight, from them, because I know, okay, this has been tested and true. Now I'm going to try it in my practice and see how my patients react. And I think that's what, differentiates somebody who's dabbling with hormone therapy versus somebody who's actually invested in it and doing it on a daily basis. So it's not a side thing that we do. This is what we do. This is it. Women are going to notice a difference when they, go change from one provider to the other. That's, I think, where all of that comes into play. Did they go over any of the new misinformation, all of that? Like how were they talking?
Dr. Gunter gave the lecture on misinformation. Important messaging that we know from the Menopause Society is compounding is less regulated than the FDA approved medications. So in 2019, the FDA uncovered over 4,000 adverse events related to pellets. They can include cancer, strokes, heart attacks, blood clots, serious infections. They talked about supplement safety, and 1 in 20 Americans are potentially taking something hepatotoxic. I have seen side effects and adverse events from a lot of things, both FDA approved and not, but one of the main themes of every time we go to menopause meetings is we need more research, right? So I do feel like when we have the research and we know something is safe and well tested, that really should be our first go-to. We've run enough experiments on women. I would rather not, subject her to more. But as a precisionist, I do believe in an N of 1 study, and that there are going to be outliers who don't respond to the conventional dose. So they gave the example of compounding progesterone when there's a peanut allergy. Of course, we don't have an FDA-approved testosterone. There was a lot of talk about testosterone and androgens and how the claims that are being made, it's true, have not yet been reproduced in large randomized controlled studies. And so making some claims that it will improve or reduce your risk of dementia, I think is a bit of an extrapolative statement. And so I think it was helpful to have that reminder that women are coming to us with a lot of misinformation. But as doctors, we know that's happening in not just menopause, everything.
In every field, you're going to get
every
that.
field,
Yeah.
There's misinformation, especially, and the statins were discussed too, and how there's even misinformation about, some menopause doctors saying that, that there hasn't been testing for women in the studies. Women have been represented. Apparently, there's not a gender or sex specific difference in the efficacy of statin medications. And that was a point that was made too. I've heard otherwise. I really have. Right. And just that testosterone is the most predominant hormone in a woman's physiology. That was also, they had a testosterone expert who flew internationally to come and tell us that's not true.
See, what I love about this society is that they are listening to what's happening out there. They have their pulse on it, and they are going after it and saying, no, this is wrong, and this is a person who's going to tell you why it's wrong. Yeah. Or this is what we recommend, and these are the reasons behind why. So it's not really about, let's say, who's more popular on social media. It's really about the data. And I think that's where always there's been this distinction between who we see out there and who's actually in the trenches doing the work. And there's a disconnect. They're not one and the same. And there's always a little back and forth going on, which I think it's healthy conversation, discussion over these topics. That way we can understand the whys behind what it is we're doing. We're not going to do things blindly anymore. There's going to have to be a reason, a compelling, good reason where I am going to give you this medication or not give you this medication. I think that's really what all of this is doing, and it's helping us create these nuances that we talk to our patients about, right?
And every year that I've been, when they say, because someone always says, it was said again today, progesterone does not improve sleep. So like half the women in the room are like, oh my God, why do they keep saying this? Right. And then they say, well, there haven't been studies. Yeah, there have been studies, but they're not, the level,
robust, the way they.
So I think the same. We never want to discount a woman's experience, myself included. Progesterone really helps me sleep better. Yeah. Period. Yeah. It does for many of my patients too, not for everybody. Similarly, when they make the claims like testosterone doesn't help with mood or energy, there are plenty of women in the room who would think otherwise and have seen otherwise. We know too, because we've so hormones to so many women, is that if we gave all the same thing, they'd all say something about how it makes them feel. So this is and I really do care to treat perimenopause because it's not easy.
No, again, you said it before, it's more personalized precision care. That's why it takes a little bit for patients to feel better. It's not a one time, and we have to kind of stay with them and guide them through it. They will see the improvements. Most of my patients, by the time they come back, I ask them, what's positive and what's negative? And overwhelmingly, I think more or positive than negative, I would have to say. The most negative I will get is, I didn't see a difference. That's it. But no one's really going to give me any more than that, negative-wise. Positive, there's always something. At least I slept better. At least, my mood or my hot flash is resolved.
Yes.
And then we work on the rest of it. So it is very particular. It's specific, and you need to have the patience and the understanding. That way you can relay that to the patient so they don't have, unreasonable expectations of this. This isn't going to be overnight, and it's not the same for everyone. And it may take a few visits to get the right combination, the right dosages for you to feel, better and decide what to do from there. You talked about heart disease, and did they go into like screening modalities? What is at least the baseline we should be doing as women's healthcare providers?
Yes, and one point they made that I thought was really important is not to minimize white coat hypertension. Because how many times have we said, oh, your blood pressure is a little high. Well, just watch it. It's probably because you're stressed, you're in the doctor's office. No, we really need to remind women, trend and track your blood pressure at home. We want to treat and get to a goal 120/80. That's messaging that we're hearing. It's not really
Over and
gender
over
specific,
again.
but really important. And I was impressed too with the mental stress ischemia, how women will present with atypical symptoms, but of course LDL lowering was a big part of the discussion. Speaking of the visceral fat, saying we should be doing waist to hip ratios or doing body composition testing. I think that's important. Attention to the BMI, attention to weight. There was discussion about overweight, obesity, the importance of how body composition is changing and increasing her risk of disease with inflammation, and how estrogen is mediating so many of those pathways. But really they were decoupling it too with the sleep. And most of the discussion was, if you can really work, and I loved hearing this because I love chronobiology and circadian rhythms, is anchoring your sleep. Really keep your body on a schedule. I feel this is important too. When the light is out, go to bed at typical times. Try to keep your body on a healthier pattern. And also the Mediterranean diet really stands out as helping the most there. But we know sleep deprivation, inadequate sleep, increase in extra calories, 250 to 385 calories a day if you're not sleeping well. So again, it's like, well, if we could treat the sleep, we can help her. And there was a whole discussion on sleep and what medications to use. And that, I think, was weird. Like the progesterone came up as, no, maybe you should prescribe these new class of sleep medication, which most of us are like, what? So I think that was different to hear. So sleep and meal timing, of course, foods rich in omega-3s, the movement, but it was really hearing more about insulin resistance, which I think is great because those are words we didn't hear a lot in conventional
What about,
conferences.
did they bring up GLP-1s at all in that whole conversation?
Yes, they talked about how GLP-1s, really can impact health. They should be prescribed when the indication is there. Again, sticking with guidelines. But we know the American College of Cardiology was actually the first to say, listen, we've tried diet and lifestyle. It doesn't work. To have improvement in cardiovascular outcomes, we need women to lose 10% of their body weight, which is very difficult to do without prescription support.
I'm really blown away by the newer topics that were brought up and discussed.
Agreed.
And we're coming along. We're making headway here. And it's wonderful to be on the forefront to see all of this happening and unfolding in front of us as, we're doing what we're doing on a daily basis. But to see it at that level, I think that is just going to help so many women, because there's so many taboos still out there over these topics. We're still working around all of that.
Well, as an obesity medicine specialist, I like to think about, just like the menopause specialist, we think of this window of opportunity. It's safer when you treat earlier and you get the benefits prospectively for decades of your life. That data is very clear. So if we can treat the weight earlier, we will get those health span extenders. We will prevent the prediabetes from going to diabetes. And it usually presents as weight first before the blood sugar goes up. And it's all related to sleep. Sleep, I think, really most women in midlife, that is the problem. And it can maintain a big risk for them into the later decades of their life.
And did they talk, I'm sure lifestyle, they went into the diet, and you said that Mediterranean. What about what was the take on alcohol?
Oh, we had a whole endowed lecture on alcohol, and the lecturer here really got my attention. 5.4% of cancer cases in the U.S. are attributable to alcohol. 4.1% of all deaths attributable to alcohol. 48% of women over the age of 18 drank alcohol in the last month, and 19% report binge drinking. Overall, alcohol use is declining, but it's declining in younger adults. Okay, so there's a 9 to 10% drop in 18 to 54-year-olds, but only a 5% drop in 55 and up. Alcohol is a carcinogen. This is language that I actually first saw in the Menopause Society breast cancer reduction guideline they put out some time ago, and I'll never forget, it was put out on March 17th, which in my neighborhood neighborhood, it's a big drinking day, St. Patrick's.
Right,
And yeah, that was a couple of years ago. But to really come out and say in the U.S. that alcohol is a carcinogen, and the top 3 modifiable risks of cancer are cigarettes, obesity, and alcohol. And the speaker even said, look, I remember in the 60s and 70s when doctors were smoking, and she thinks that 40, 50 years from now, people will be saying, I remember when doctors were drinking alcohol.
Yep.
And how many of us in the room are still not giving up drinking alcohol when the data is so clear, especially for breast cancer, that alcohol really, it turns into acetaldehyde, it causes oxidative stress, it depletes folate. All of these are very toxic to estrogen metabolism. And so how these changes in our metabolism of hormones can really impact. So that was a big deal, talking about alcohol. And really it's 2.5 additional cases of cancer per 100 women, right? And so we know the increased risk of breast cancer in a woman from the Women's Health Initiative study, 1 in 1,000 extra women will have breast cancer. This is 2.5 per 100.
100. Yeah.
Yeah,
This is
100.
much bigger. Again,
Much bigger.
why didn't this make the headline? As big as that one did, I do remember earlier this year, New Year's, I think it was, where the FDA did come out about alcohol being.
The Surgeon General.
The Surgeon General came out with that.
Right.
Sorry.
Yeah.
The Surgeon General came out with the alcohol correlation to disease, cancer, everything. And
Yes.
I posted it and everybody went wild on me. Are you going to be this now? And I said, listen, I'm just putting out the facts of what it is. This is the data, what it's showing us. This is a modifiable risk factor that we can work on. But hey, we're all about being out there and having a drink. I get it. But there are changes that can be made that, you can just help yourself. We're all worried about not taking hormones because we don't want to get cancer, God forbid, right? But that correlation has been debunked and demystified for 23 years, but it's still standing. But the alcohol one that's straight in our face, that's staring us down, we push that to the side. No, I don't want to do this or that. But I see a change coming, especially in the younger population. You're not wrong. I see it just in my area. And younger patients, they're just not drinking the way we did when we were in that, 20s, 30s. And I think it has a lot to do with the longevity space, to be honest with you. I think that's what's driving it, is the Brian Johnsons of the world and, Kayla.
Right.
It's that where we want to live longer, but we want to live well. And how do I do that? You start
I think
before
the wearables.
anything starts. The wearables.
Yeah, the Whoops and the Oura rings and the Apple Watches.
And the CGMs and all of that. It's all coming into play. Yeah.
When you see what alcohol does to your sleep, you're like, oh my gosh.
Yeah.
And so, I think especially, I will say this is something for dementia I really see as a modifiable risk factor myself. Of course, obesity is modifiable. One of the reasons I am so liberal about treating weight, especially my breast cancer patients, is we know there's great data that show the GLPs have reduced recurrence of breast cancer for women. And here we go. We have a modifiable risk factor of obesity when we treat it actively and continue treatment to maintain weight loss. We see changes in the data in such a short amount of time. And that's where the American College of Cardiology, they love semaglutide now that has been shown it reduces all-cause mortality, all cardiovascular risk reduction in overweight or people living with obesity, not diabetics. So this is where, too, I think women are starting to realize, look, I have heart disease, too. I'm more likely to die of heart disease than anything else. One of the other keynotes was a woman who is literally making our future heart transplant for us. So personalized heart transplants. There's a whole lecture about it. Very regenerative medicine, much about longevity and health span. So this is really I get most excited because it was actually Dr. Jennifer Garrison from the Buck. She says, what am I doing here? I'm here because that's how important ovarian aging is to health span.
And, that's what's so amazing about all of this is that there are things that can be done earlier to get better, to prevent, so that future generations basically will have an easier time with this midlife transition. And it's not going to be such a mystic thing happening. It's just
Correct.
another part of life. Just like puberty, just like everything else, you're just going to go through it. There is no if, and, or but about it. And you don't have to worry about any of that. And I think this is just groundbreaking. And the fact that these were topics that were discussed at such a high level in terms of the society, I think we're moving in the right direction. And there's light at the end of that tunnel. It's coming and we're seeing it.
I think it really starts with women advocates, right? The women are advocating for it. Clearly, there's a market for it, but also the research money is there in a time when we're losing some NIH grants and we have some issues there with funding. The Menopause Society made multiple announcements, $5 million donation here, $5 million donation there. Like, it really brought so much, because so many of the lectures are like, well, we just don't have enough research. You know, I feel like every time we talk about women's health and hormones, well, we need more research. And, you know, what I love about this meeting too, I get to see the young researchers. They do the abstract presentations in the big room. They bring out the lunches and you see these young scientists contributing to our daughter's health. And that's, you know, so that's how I always take a picture to send my daughter, who loves biology and chemistry and neurology as much as we do.
So the takeaways were basically, I mean, I can't even begin with all of this, but basically they went through perimenopause, right? They talked all about it. It's a thing now, where before it was all about menopause. And now, so perimenopause is making its debut, I guess. We need that because that's the missing piece. Those are the missing years where women are just not understanding, not connecting the puzzle points, and not taking care of themselves or being taken care of by their providers. So perimenopause, misinformation. So what's the source? Who's telling you what? And to be really cautious with what you hear out there, and to make sure you take it to a provider who understands and who can kind of break it down for you and say what is and what isn't correct. And the whole longevity aspect, I love that, you know, we're part of a whole different, you know, consortium with the longevity healthcare, but the fact that it's becoming such a mainstream topic, this is it. This is what we've been working for so long, to see it come to fruition like this. Again, on such a platform, I think that's wonderful. We're only going to be helping women going forward.
And really important domains that I didn't touch on: bone aging, osteoporosis, osteopenia prevention, lots of material presented there. Then the genital urinary syndrome of menopause, of course, really important lectures there, all going back to longevity, especially frailty. And I think when I'm talking to patients, I'm saying, okay, I want to help you with your symptoms today, help you, but really I'm thinking about your brain, your bones, your heart, all of it for the next few decades. Because that's, I think, so much of taking care of the perimenopausal woman is similar to a pediatrician that goes into adolescent medicine, right? These are people who are really struggling. They have unique needs. And I do think these hormonal fluctuations, the best, Dr. Gordon, she is a woman studying perimenopausal mood fluctuations, and she had her researchers plot the mood fluctuations, and it was such a scattergram. It looks like abstract art, you know. So she's like, it's unpublished data, because how do you publish that? There's all you can say is this is chaos. And those of us who have raised teenagers, we know it too. And I do think we've protracted puberty. It's messier, all these endocrine disruptors, the inflammation, the issues. We've also seen protracted perimenopause. And I do think our mother's menopause was a little more brief and not as protracted, just as our puberty was not so messy. That's speaking in generalizations. Of course, everyone's different. Listen to women. I do feel that there's a lot of gaslighting in conventional medicine. There were so many lectures like, what do women usually say? They've been to so many doctors, no one's listening. Or they're giving them other drugs, not talking about menopause.
So thank you so much. I think that was just such an eye-opening discussion, you know, to see what happened, what was talked about. And, you know, it just gives us hope and gives us more energy to keep going every day and taking care of our patients. Thank you so much for being here.
Thank you.
And we will put all of your information out there so patients can follow you and see you and go from there. And I'll let you know when all of this goes up.
Okay. Thanks,
Thank you,
Jila.
Catherine.
Great to see you.
Always nice to see you.